Hi everyone, this is Cheryl Marshall, Interim Clinical Educator for the Postpartum Care Unit and Inpatient Gynecology Unit at London Health Sciences Center. Today I'm presenting a refresher on nursing care management for hemorrhage in the postpartum and post-vaginal hysterectomy patient. This presentation is intended for all of our postpartum and gynecology nurses to provide excellent nursing care to manage a patient experiencing a hemorrhage on either unit, in addition to better prepare all staff on how to handle both a postpartum hemorrhage and post-vaginal hysterectomy hemorrhage if required to float to one another's unit. The objectives of this presentation are for nurses to be able to classify both a post-vaginal hysterectomy hemorrhage and a postpartum hemorrhage, and to accurately assess and identify the potential causes of a hemorrhage in each patient population, and for the nurse to identify the presence and severity of hemorrhage amongst both patient populations, and to effectively outline and follow the care priorities to manage a hemorrhage in both postpartum and post-vag hyst patients, and to be able to apply additional considerations to their practice to further enhance patient and family-centered care and improve patient safety outcomes. Now let's dive into how we differentiate a hemorrhage amongst both patient populations. A postpartum hemorrhage is identified as losing more than 500 mils of blood following a vaginal delivery and over 1,000 mils of blood following a cesarean section. However, any amount of blood that threatens a woman's hemodynamic stability can be considered a hemorrhage. This is important when we're thinking about our already at-risk patients, including those diagnosed with severe anemia, low platelets, known coagulopathy, and a decreasing hematocrit below 30. Unlike PPH, literature does not quantify a hemorrhage in a vaginal hyst post-op patient. Rather, in this specific patient population, minimal to no bleeding is expected post-operatively. So if continuous, steady, bright red bleeding is noted with or without the presence of vaginal packing, we are on high alert for a hemorrhage and will be notifying the physician team right away. We also need to be mindful of a hidden hemorrhage with no vaginal bleeding but worsening patient status in relation to deteriorating vital signs, hematocrit levels, and increased pelvic, abdominal, or flank pain noted. This could be a sign of an internal hemorrhage. The medical team should be notified immediately. Before discussing hemorrhage care management for both patient populations, it is important to review the root causes that result in hemorrhage so our care management is appropriately addressing the medical need. There are four main physiological causes that underline a PPH, commonly referred to as the 4Ts. The first being uterine tone, the most common cause of PPH occurring in about 70% of postpartum hemorrhage patients, resulting in a poorly contracted uterus, or in other words, uterine atony. This could be due to issues such as a distended bladder, over-distended uterus, uterine exhaustion from prolonged labor, or a precipitous labor. If the patient received uterine relaxing meds such as nitroglycerin or experienced an infection in labor such as chorioamnionitis. The next T refers to retained tissues, either retained placenta products or blood clots that are preventing the uterus from being able to clamp down effectively. This is more common in women that have had manual removal of their placenta or had placental abnormalities diagnosed in pregnancy, such as a placental previa or a placental abruption. Trauma, the third T, refers to damages to the tissues, whether that be uterine, cervical, or vaginal, usually due to vaginal assisted deliveries, precipitous deliveries, high parity, or birth complications such as a shoulder dystocia or, again, a manual removal of the placenta. Last T, thrombin, refers to pre-existing or pregnancy-acquired coagulation problems such as DIC, severe preeclampsia, or HELLP syndrome. It's important to understand how a postpartum hemorrhage is classified amongst the three stages, progressing from mild, moderate, to severe. Our goal as nurses and healthcare professionals is to keep our patients from experiencing a moderate to severe hemorrhage, where they are likely to display more severe signs of hypovolemic shock due to the blood loss. Remember, postpartum women can compensate for a longer period of time compared to other patient populations before their vital signs will start to reflect the amount of blood loss. If vitals become unstable and patients are showing a decrease in level of consciousness, pallor, delayed cap refill, and patients are likely entering a severe shock and can be considered in the third stage of hemorrhage. It's important to continually assess your patient's vitals and monitor and weigh saturated pads so we have an accurate measurement of blood loss to determine the stage of hemorrhage and our next appropriate steps of action in the plan of care. I want to remind everyone that we have an algorithm for postpartum hemorrhage that occurs on the postpartum unit, and it's posted in each one of our wings. As you learn in your unit orientation, this algorithm serves as a guide to our nursing care, providing instructional steps to outline our nursing actions as well as our bedside monitoring. This algorithm is also available on the LHSC intranet under the Postpartum Care Unit tab, under Guidelines, Standards, Resources, under H for hemorrhage, PPH. Switching gears, the source of hemorrhage for a post-vag Hyst patient is either indicative of bleeding from the sutured vaginal cuff or bleeding from the vascular pedicles of the uterus. The first cause and most common is an active bleed occurring at the vaginal cuff or a bleed that has accumulated at the cuff, such as a vaginal hematoma. The second cause of a post-op hemorrhage may result in little or no observed vaginal bleeding, as blood is actively pooling in the abdomen. This refers to a retroperitoneal hemorrhage or an internal hemorrhage. Now that we understand the potential causes of hemorrhage in both patient populations, we will next discuss the nursing care management. As evident in the previous slides, we manage these two hemorrhages differently based on the sources of bleeding. However, general principles of hemorrhage management apply, including early identification of abnormal bleeding or suspected internal bleeding, a thorough head-to-toe assessment with continuous and repeated vital signs, to detect changes in patient status, paying particular attention to reported pain, severity, location, and the quality of pain. We also want to monitor urine output if a Foley is in situ and save all pads for the most accurate estimated blood loss measurements. We want to notify the team immediately and report all significant findings, while also grabbing skilled hands on the floor to help manage care and gather resources. We want to obtain supplies for fluid resuscitation, thinking about a secondary IV line access with a large bore needle, Foley catheter insertion if not already done, and drawing blood work as per orders, and administering O2 therapy and medication. Thinking about pre-medicating patients before further interventions are sought as per physician's orders. Our next steps are to administer blood product replacements and prepare to transfer patients safely to the OR for further exploration and/or interventions. This may include placing a Bakary for a postpartum patient. At this point, we might be preparing to initiate LHSC's massive hemorrhage protocol as per the physician's orders. Please see the attached handout on this protocol that highlights the initial steps of inputting this into Cerner. Remember, we're keeping all patients NPO at this point, saving and weighing pads and remaining with the patient at bedside. Let's dive into PPH-specific nurse management. As soon as heavy bleeds and clots are noted, we want to notify the OB team immediately and update our charge nurses. We also, depending on the severity of bleeding and the deterioration of patient status, may want to notify anesthesia, RT, other nursing staff, and PSWs to help gather needed supplies. It is crucial that we stay at the bedside and perform continuous assessment of lochial flow, saving and weighing pads for later, as this provides a great visualization of blood loss for members of the team to then assess. We want to have a fundal assessment with a firm fundal massage in addition to our vitals, and perform a head-to-toe assessment complete with particular attention placed on patients' level of consciousness, pallor, cap refill status, and respiratory status to detect for progressive signs of shock. We want to empty the bladder and leave a Foley catheter in situ to take pressure off the uterus and later for accurate output measurements. We want to initiate IV resuscitation, gather our PPH kit, and administer our PPH meds as per physician's orders. Remember, we want to ensure we know the patient's history. There could be certain health conditions that are contraindicated, impacting patient safety when we administer some PPH meds, including Hemabate for our asthmatic patients or Ergovine for our hypertensive patients. Also, we want to consider the potential for tranexamic acid or TXA. We want to gather supplies for repeated blood work as per orders, specifically looking at a CBC and ensuring we have a current group and screen in the system. We want to review the patient's chart to review previous lab results for baseline, allergies, orders for blood products, and ensure consent for blood products are signed in the patient's chart. We want to administer any preemptive pain meds as per orders and ensure a patient is safe while keeping the family and patient informed and updated as best we can on our plan of care. Now, looking at the hemorrhage care management for a post-vaginal hysterectomy. Our care management begins with a rapid diagnosis of presence of abnormal bleeding or signs of an internal bleed. Nurses at bedside should assess the perineum, vaginal packing if present, and flow of bleeding with or without vaginal packing, and save all saturated pads. Insert the Foley catheter if not already in situ. We also want to be judicious about monitoring vital signs for hemodynamic stability, paying particular attention if patients are displaying clinical manifestations of hypovolemic shock due to this loss of blood. Like in a postpartum patient, we want to assess for pallor, level of consciousness, cap refill, and do a thorough respiratory and abdominal assessment. All significant findings should be reported to the team immediately. We want to initiate fluid resuscitation, giving isotonic fluids such as normal saline or Ringer's lactate as ordered, being mindful of our patients on stringent fluid restrictions postoperatively. We want to reinsert the Foley catheter to monitor strict urine output and have patients kept on NPO. Ensure IV access with a large bore needle is in situ and initiate blood product replacement as per orders, thinking about your red blood cells and your plasma. We want to gather the gynae procedure cart for the team for possible re-exploration at bedside and administer pain medications as needed as ordered to pre-medicate for further exploration. We want to also consider our hypertensive patients prior to giving any pain meds, specifically when giving NSAIDs and antithrombin meds. Ensure vaginal packing is in the cart to apply pressure on the vaginal cuff if it is identified as the source of bleed. With Monzol's cream, a hemostatic agent applied to the vaginal packing, and ensure good light source for physician visualization. We also want to draw blood work, CBC, and a group and screen, monitor the hematocrit, and perhaps along with it, an INR and PTT values. Prepare the patient for transfer back to the OR if required, and ensure close and constant surveillance of the patient with open communication with patients and family members present at the bedside to reduce anxiety. Additional considerations to enhance our nursing practice and the patient care experiences are that we're providing emotional support to patients and family members that are present as best we can when we're managing a hemorrhage, in addition to keeping the patient and family updated on the patient status and plan of care to instill confidence in our team, in addition to decreasing patient anxiety. This may mean delegating this task to another member of the healthcare team. We also want to ensure newborn safety and well-being if a newborn is present in the bedside for a postpartum patient. This may mean assigning another nurse to oversee newborn care while the primary nurse manages and stays with this patient. We need to be mindful of using the words and language such as hemorrhage around patients and family members, as they may equate this to death or dying. Please ensure we are doing our best to remain calm and composed while managing a hemorrhage to limit patient and family anxiety. A debrief with the family and team members involved should be done following the complete management of a hemorrhage to highlight areas of success and also room for growth. A debrief with the family and patient if present afterwards to explain thoroughly what has taken place and the next steps in plan of care is beneficial so the patient stays well informed. We want to also ensure a complete handover is given to a receiving nurse and that we accompany the patient if going off unit to give a comprehensive handover. We want to make sure our documentation after hemorrhage is done in the moment as best we can and up to date in the chart in case the patient goes to transfer back to the OR or another unit for further care management. We want to chart all significant findings under our progress note, and we always want to continue to assess the need to don for additional PPE when caring for patients, especially when coming into contact with all these bodily fluids. Please reach out to me if you have any questions regarding the material presented today. I would be more than happy to help and go over and review anything with you. Thank you so much for your time.